Imagine walking into a hospital to give birth. The roof is leaking. The lights are out. The nurse asks you to bring your own surgical gloves, your own cotton wool, and fuel for the hospital generator, or she cannot help you. This is not a war zone. This is not a refugee camp. This is Cameroon in 2026. On December 18, 2025, President Paul Biya signed the nation's 2026 budget into law. The health sector received nearly 400 billion CFA francs, a massive 30% increase from the year before. The Minister of Public Health stood before Parliament and promised modernization, better care, and improved governance. So why, in a country spending more on health than ever before, are doctors working without X-ray machines?
Wait, what?
Why are nurses delivering babies by flashlight? Why are the people who need care most paying for it with money they don't have? The answer is not that Cameroon lacks money for health. The answer is that Cameroon's health system is broken, structurally, financially, and deliberately. And it has been broken for over 20 years. This is why. To understand why the system is broken, you first have to understand what it is supposed to serve. Cameroon. 475,000 square kilometers. 30.6 million people. Growing at 2.6% every year. A decentralized unitary state, at least on paper, with French and English as its official languages. But look closer. The poverty rate is 38.6%. Underemployment sits at 70%. Inflation is 3.4%. Extreme poverty traps between 22 and 23% of the population. If you are born here, your healthy life expectancy is 51 years. Just 51. The overall burden of disease is measured at 13.8 million disability-adjusted life years. Food reserves. 0 tons.
Alert.
When disaster strikes, the country relies entirely on the United Nations World Food Programme.
Alert.
And corruption. Cameroon ranks 142nd out of 182 countries worldwide. This is the foundation. This is the population the health system is supposed to protect. And this is why failure here is not abstract. It is fatal. On November 28, 2025, Dr. Manouda Maleki, the Minister of Public Health in Cameroon, appeared before the National Assembly's Finance Committee. He laid out 4 priorities. Health promotion. System modernization. Better quality of care and emergency response. Governance and strategic oversight. For 2026, his ministry was allocated 391.27 billion CFA francs. That is a 30.86% increase from 2025's 297 billion. On the surface, this is what progress looks like. But the surface is exactly where this story falls apart. Because that entire health budget makes up just 4.41% of the national budget.
Wait, what?
The World Health Organization says 5% is the minimum. And back in April 2001, at the Abuja Summit, African nations, Cameroon included, pledged to allocate at least 15% of their budgets to health. 25 years later, Cameroon has never hit that target. Not once. So the first crack in the system is this: even when the government claims to be investing more, it is still investing less than it promised. Less than its peers agreed was necessary. And far less than its population needs. But here is where the system is not just underfunded. It is structurally rigged. Cameroon's health budget is legally divided into 2 parts. The operational and salary envelope, which consumes 55 to 60% of all health spending. This is salaries, allowances, benefits, the cost of keeping people on payroll. The second part is the public investment budget. 35 to 40%. By law, this money is locked. It cannot be diverted to salaries. It is meant for infrastructure, equipment, and upgrades. Sounds reasonable, right? Except for one devastating reality. The people on payroll, the specialists, the administrators, the high-ranking officials, are overwhelmingly concentrated in the capital, Yaoundé, and the economic hub, Douala. So the money follows them. It stays at the top. In 2004, Cameroon published its first public expenditure tracking survey. PET 1. It was supposed to improve transparency. Instead, it revealed a number that should have triggered national outrage. 70% of the health budget never leaves the central level. 70%. Absorbed by the ministry headquarters, national program secretariats, and elite central hospitals. That leaves 30% for everyone else. 10 regional health delegations. 189 health districts. Thousands of rural integrated health centers. All fighting over what is left. And this is not old data. The National Statistical Institute has confirmed this pattern again and again. The government has known about this 70-30 split for over 20 years. And for over 20 years, nothing has changed. Why does the money get stuck? 3 structural reasons. First, the payroll factor. Over half the budget is personnel cost. And the personnel are in the cities. So the cash flows to the cities. It is that simple. Second, bureaucratic bloat. Every franc meant for a rural clinic passes through multiple financial intermediaries. Each layer adds delay. Each desk takes a cut, in time if not in money. Public expenditure reports consistently note that the high number of players in the expenditure system at peripheral levels is a primary cause of resource starvation. Third, and perhaps most important, there is no institutional incentive to fix this. The central level controls the budget. The central level writes the rules. The central level benefits from the status quo. Decentralizing funding would mean decentralizing power. And that, for the past 2 decades, has been politically untouchable. So the system does not break by accident. It breaks by design. So far, we have talked about a system that is broken by structure. About budgets that grow at the top while the bottom starves. About bureaucracy that absorbs resources before they ever reach a patient. But there is another layer. A darker one. Because in Cameroon, the health system is not just inefficient. It is not just centralized. It is a system where money, your money, patient money, taxpayer money, international donor money, has a long and documented history of simply disappearing. In 1993, over 30 years ago, Cameroon passed a law that seemed wise. Every public hospital in the country was required to deposit 10% of its monthly revenue into a national health solidarity fund. The purpose was clear, to create a reserve for unforeseen emergencies. A safety net. A promise that when disaster struck, the health system would have cash ready. For nearly 3 decades, hospitals complied. Citizens paid their fees. 10% went into the fund. Millions upon millions of dollars, paid by sick Cameroonians into a pool that was supposed to protect them. Then COVID-19 arrived. And the fund, the emergency reserve built over 27 years, was either empty or simply unaccounted for. No transparent records. No clear answers. Millions of dollars vanished into a complete absence of accountability. The very fund created to protect the population during a health emergency had evaporated just when the emergency came. If the Solidarity Fund scandal was a slow disappearance, what came next was a brazen heist in broad daylight. As COVID-19 spread across Cameroon, the government established a multi-million-dollar emergency response budget. 23 ministries were involved. International attention was fixed on the country. The stakes were life and death. And then the audit chamber investigated. What they found was staggering. 180 billion CFA francs. That is $335 million. Stolen. Mismanaged. Vanished into phantom contracts for medical gear that never arrived. Into invoices for supplies that existed only on paper. Into a labyrinth of fake vendors and fictitious deliveries while frontline workers begged for basic protective equipment. $335 million. During a pandemic. While nurses reused single pairs of gloves. While district hospitals had no ventilators. While citizens died in corridors. The money did not vanish because the system was confused. It vanished because the system allowed it to. And the theft was not limited to domestic funds. The Global Fund, one of the world's most important health financing institutions, provided Cameroon with millions in grant funding specifically to combat HIV, tuberculosis, and malaria. These were not loans. These were gifts from the international community, earmarked for the sickest and most vulnerable Cameroonians. But international auditors did their job. And what they found forced the Global Fund to do something almost unprecedented. They demanded their money back. 1.3 million euros. 852 million CFA francs. The audit uncovered severe fiscal chaos. Ineligible expenses. Stolen medicine. Financial records so broken that the Global Fund, an organization whose entire mission is to help developing nations, had no choice but to formally demand repayment. Think about what that means. An international body dedicated to saving lives in Cameroon concluded that giving money directly to the Ministry of Public Health was too dangerous. That the system could not be trusted. That the funds meant for malaria patients and HIV treatment programs were safer being recalled than being left in Cameroonian hands. When the guardians of global health stop trusting your health ministry, the diagnosis is no longer bureaucratic. It is criminal. 3 scandals. 3 decades. 1 unbroken pattern. A solidarity fund built by patients, empty when they needed it most. A pandemic budget larger than some nations' entire health spending, siphoned into phantom contracts. International grants for the dying, stolen so brazenly that donors demanded their return. This is not a story of well-meaning inefficiency. This is not a story of growing pains or administrative complexity. This is a story of a health system where money does not get stuck. It gets taken. And when you understand this, the 70-30 split starts to look different. It is not just an accident of bureaucracy. It is the architecture of a system designed to concentrate resources where they are easiest to control, easiest to obscure, and easiest to divert. The flashlight in the rural clinic is not just a symbol of neglect. It is a symbol of theft. Of a system that had the money, your money, donor money, emergency money, and chose, again and again, to let it vanish into the dark. When 70% of health funding stays at the top, the bottom collapses. And the bottom is where most Cameroonians live. At district and subdivision hospitals, doctors work without basic diagnostic tools. No X-ray machines. No ultrasound scanners. Young physicians face an impossible choice: turn away emergencies or perform complex procedures under unsafe conditions. The ethical toll is enormous. The burnout is rapid. Nurses carry the heaviest physical load. With no budget to hire adequate staff, nurse-to-patient ratios are unsustainably high. Nurses perform tasks beyond their training because there are not enough doctors. And they do it without basic protective equipment: no gloves, no masks, no gowns, exposing themselves to tuberculosis, hepatitis, and countless other infections. Laboratory technicians are paralyzed. Reagents run out. Sterile tubes disappear. When analyzers break, there is no repair budget. Technicians fall back on manual microscopy, slower, less accurate, and devastating for patients who need fast, correct answers. For ordinary citizens, the cruelty is financial. Because local clinics receive almost nothing, they charge patients for everything. Syringes. Cotton wool. Surgical gloves. Fuel for the generator. Patients delay seeking care because they cannot afford to walk through the door. They arrive at hospitals only when their conditions are critical or terminal. Without functioning labs, doctors make presumptive diagnoses. They treat for malaria or typhoid based on symptoms alone. This is not just bad medicine. It wastes drugs. It breeds resistance. And it kills people who had treatable conditions. And at night, in facilities without 24-hour electricity, nurses deliver babies by flashlight. By mobile phone torchlight. In rooms where the paint is peeling, the walls are cracked, and the plumbing is broken. Because in Cameroon, you can find money to build a clinic. But you will not find money to fix its roof. Here is what the 70-30 split actually looks like when the doors open in the morning. At the Central Hospital in Yaoundé, the Minister of Public Health inspects a fleet of newly purchased operational ambulances. High-tech diagnostic imaging equipment is unboxed for the regional hospital. Dialyzers arrive by the pallet. The plateau technique is modernized. The headlines write themselves. 200 kilometers away, in a district hospital with no budget, a nurse is sterilizing a single pair of gloves for reuse. The ambulance bay is empty, not because there is no need, but because the one vehicle the district was assigned has been grounded for 6 months. No fuel allowance. No spare parts. No mechanic on payroll. This is not hyperbole. This is the arithmetic of abandonment. When the public system starves the periphery does not stop getting sick. It simply stops trusting the public system. And so a parallel economy of survival emerges. Private clinics. Unregulated pharmacies. Traditional healers operating in the vacuum left by the state. In towns where the public hospital has no reagents, no gloves, and no running water, a private clinic opens in a converted storefront. It charges what the market will bear. And the market, in a country where 40% of people live in poverty, will bear almost anything to stay alive. The proliferation of private clinics is not evidence of a thriving health market. It is evidence of state failure. When citizens cannot rely on the public hospital their taxes fund, they are forced to sell assets, borrow money, or simply go without unless a private provider offers an alternative, however unaffordable. The out-of-pocket mandate in public facilities accelerates this exodus. Remember, when a patient walks into a government health center, they are not receiving free care. They are buying their own syringes, their own cotton wool, their own gloves, their own fuel for the generator. The state facility has become, in practice, a shell. A building where care is theoretically available, but only to those who can afford to stock it themselves. So the sick citizen faces a devastating calculus. Option 1, the public hospital, where treatment is theoretically subsidized but practically impossible without personal funds for basic supplies, where diagnosis is presumptive because the lab has no reagents, where the nurse is exhausted and underprotected, and where the lights may go out mid-procedure. Option 2, the private clinic, where care is faster, cleaner, and more reliable, but where a single consultation can consume a family's weekly income. Where the doctor is better equipped not because the state invested in them, but because the clinic owner passed the cost directly to the patient. This is the paradox of Cameroon's health system. The state spends billions. The citizens still pay twice. Once through taxation. Once through desperation. For the poorest citizens, neither option is real. They delay. They self-medicate with whatever is available at the market. They visit traditional practitioners not out of cultural preference, but because the former system has priced them out entirely. By the time they arrive at any facility, public or private, their condition is advanced, their resources are depleted, and their chances are diminished. The stretched resources of the public hospital do not just reflect mismanagement. They reflect a quiet privatization of survival. The state has not formally abandoned public health. It has simply withdrawn the resources necessary to make it function, forcing citizens to absorb the cost of its absence. And so the cycle tightens. The public system deteriorates. Citizens flee to private alternatives. The state points to the existence of private clinics as proof of a functioning health sector. But the clinics are not a solution. They are a symptom. A symptom of a system that built ambulances for the capital and left the districts in the dark. With a flashlight. And a prayer. Under these conditions, the only rational decision a healthcare worker can make is to leave. And they are leaving in accelerating numbers. Nurses and midwives are departing for the United Kingdom, Canada, Germany, and the Gulf. Not just for higher salaries, though that matters. They are leaving for predictable working hours. For career development. For environments where their skills are valued and their safety is protected. At the central level, administrators receive housing, vehicles, and generous allowances. At the peripheral level, nurses often work for years as temporary contractors on minimal wages. Even those who are formally part of the civil service face long administrative delays before receiving their state salaries. This is not a staffing shortage. This is a justice failure. A system that starves its frontline workers of resources, dignity, and security cannot be surprised when those workers walk away. Until Cameroon fixes the flow of money, it cannot stop the flow of people. Every year, the headlines get a little better. Budget increases. New promises. Bigger numbers. And every year, the reality on the ground stays the same. This is the central lie of Cameroon's health narrative. That the problem is a lack of funding. It is not. The problem is where the funding goes. The government has known about this 70-30 centralization trap since 2004. It has commissioned report after report. It has received recommendation after recommendation. Increase transparency. Reduce intermediaries. Move money to the districts. The advice has been consistent, clear, and ignored. Because fixing this does not require more billions at the top. It requires political will. It requires the central level to let go. To trust the periphery. To fund the district hospitals, the subdivision centers, and the rural integrated health centers where the vast majority of Cameroonians actually seek care. The budget keeps growing. The speeches keep coming. And the people at the bottom keep waiting in the dark. So what would a functioning system look like? It is not complicated. Imagine if just 15% more of the health budget flowed directly to district-level facilities. Imagine laboratories with working equipment and stocked reagents. Imagine nurses with adequate protective gear and reasonable patient loads. Imagine patients who seek care early because they can afford it. Imagine doctors who stay because they have the tools to do their jobs. Other developing nations have decentralized their health financing successfully. The models exist. The research exists. The only missing ingredient in Cameroon is the willingness to change who controls the purse. The structure is the disease. Until the structure is treated, every budget increase is just more medicine poured into a broken pipeline, absorbed at the top, while the bottom starves. Cameroon does not need a bigger health budget. It needs a braver one. This is the story behind the budget speeches. The numbers are public. The pattern is 2 decades old. And the only question left is whether anything will change before another generation grows up in the dark. If this breakdown changed how you see public health spending, subscribe for more investigations into where the money goes and who it leaves behind. Leave your thoughts in the comments. And if you know someone who needs to see this, share it. Because systems do not break in secret. They break in plain sight.